welcome. Thanks for joining us today. I'm so happy to be here to talk with you guys over your lunch. So just a little brief introduction. I'm Amy Armstrong. I'm a GYN oncologist at UH. So that means that I did my initial training in OBGYN, so OBGYN, delivering babies and pap smears and all that. And then I did an extra fellowship in cancer care. So I primarily only take care of patients with gynecologic cancers now. So cervical, uterine, ovarian, and vaginal and vulvar cancers. And so that's what we're going to focus on today because it is, I'll say this a couple times, Gynecologic Cancer Awareness Month in September. So I was really excited to be invited. So I just have a brief presentation. We'll definitely have time for questions, and then I think we have someone who wants to share as well their journey. So just my objectives today. I just really want to educate you on the care of your bodies and empower you to make good health decisions about what to do for your overall health. I want to review just the types of gynecologic cancer that we see and some of the screening strategies. And then because we don't have great screening strategies for every type of cancer, I want to talk about some of the things we can do for prevention or ways to figure out if you're at higher risk, and also what sort of symptoms and things you would want to watch out for. So like I already said, September is Gynecologic Cancer Awareness Month, and there will be about 100,000 new cases diagnosed in the U.S. And 34,000 deaths related to gynecologic cancers this year. So that's quite a high number, and chances are I bet everyone in this room knows at least one person affected by one of these cancers. So this includes ovarian cancer, uterine cancer, cervical cancer, and then vulvar and vaginal cancers kind of get grouped together. So before we talk about the cancers, I just want to review the anatomy. I know most of us are familiar with this, but it's always good to have a review. Just have this diagram here on the right. Can you see my mouse? Okay. Showing the different parts of the gynecologic anatomy and the parts that can be affected by cancer. So I think most of us are familiar with this model of the two ovaries, fallopian tubes that connect the ovaries to the uterus, which is the womb, so when there's a pregnancy, it's in the uterus, and then the cervix, which is really just the gateway at the top of the vagina, between the vagina and the uterus. So you can get a cancer of any of these parts of the anatomy. So you can get cancers of the uterus itself, of the ovary, the cervix, the vagina, and the vulva. I have another picture here just of the vulvar anatomy. So that's the external genitalia. You can get cancers on the vulva, and these are actually like skin cancers. Just like you can get a skin cancer anywhere else on your body, you can get one on the vulva. And it could be just here on one of the labia or even kind of closer to the inside of the vagina. So just wanted to make sure we're all, on the same page with some of the anatomy we're going to talk about today. When you go to the doctor, whether it's an OBGYN or your primary care doctor for what we call like a well person or a well woman exam, if they perform a pelvic exam, it usually includes like someone visually inspecting the outside of the genitalia. So they're looking on the vulva for any bumps or lesions or bleeding. They're looking at the inside of the vagina. That's when they put the speculum device in, which I think I have a picture of in a later slide. Looking at the vagina itself, looking at the cervix, looking for any irregularities or abnormalities. And then they may also do what's called a bimanual exam, where you actually they would insert their fingers into the vagina and feel with their other hand on the stomach just to feel the size of the uterus. And sometimes that's done during pregnancy. Outside of pregnancy, it's done to feel if there's any uterine tumors or any abnormalities. You can actually feel the ovaries, through that type of exam to see if they're enlarged or if there's anything unusual. So that's usually what is happening when you're going for those types of visits. So we're going to get into the different types of cancer that can develop and how we can screen for them and prevent them. So the first one we're going to talk about is uterine cancer, and this is the most common type of gynecologic cancer that we treat. Risk factors for uterine cancer are really just age. I mean, as we age, you just become at higher risk for this type of cancer. It's not usually related to a genetic condition or anything. It's usually just a spontaneous process. Usually this is going to present with bleeding, and this is bleeding that's abnormal or unusual. So especially once you've gone through menopause and you've stopped having periods, if you start having bleeding again, there are other causes, but definitely cancer is something we're thinking about and we want to screen for. Definitely can present with pain, abnormal discharge, enlargement of the uterus can also be another sign. If someone is concerned for uterine cancer, usually the next step is a biopsy of the inside of the uterus. That's called an endometrial biopsy, and some of you may have heard of that or seen it before. That's usually done in the office, where the doctor just puts an instrument inside the uterus and then takes a sample of this inside lining of the uterus there, the endometrium. Now, most uterine cancers arise from the endometrium, or the lining of the uterus. You can actually also get cancers of the muscle of the uterus, and those are usually called uterine sarcomas. Those are less common. They're more of a rare cancer, but can behave in a very aggressive fashion, and those are even harder to detect. So this is why it's important, if you have symptoms that you're worried about or that don't seem normal, or especially bleeding after menopause or bleeding that's not at the right time, is it, a good time to go get checked out. The next cancer I just want to give a brief little overview about is ovarian cancer. And this one is also tricky because ovarian cancer doesn't have a good screening test. We're going to get into some of the details of other cancers that do have good screening tests, but for ovarian cancer, we haven't yet found that good, perfect test that helps us detect it at an early stage. So we think a lot about ovarian cancer risk. About 20% of ovarian cancers actually come from a genetic mutation. So there's like a genetic reason why you would have gotten the cancer. Because of this, anyone who has like a family member that had ovarian cancer, like your mom or your sister or your aunt or your cousin, or a family member that had breast cancer at a young age, like in her 30s or 40s, that kind of raises our antenna a little bit, and we would think about genetic testing in those patients to try to determine if you might be at higher risk. Because there's no good screening test, if you are found to have a mutation that puts you at higher risk for ovarian cancer, there might even be a recommendation to remove your ovaries once you're done having children to try to prevent it from happening. So if you have, that in your family history, like, your sister had ovarian cancer or your mother, it's always a good thing to bring up with your doctor, like, hey, do I need to see a genetic counselor? Maybe I should have some genetic testing to see if I might be at risk. The symptoms of ovarian cancer are also hard to detect because they're pretty vague. I mean, who here hasn't had bloating at some point? Like, that's like a normal part of everyday life. But with ovarian cancer, the bloating can be severe, it can persist. Bloating that lasts weeks or months, that's not normal. You eat something funny, you're bloated for a few days and then it gets better, that's okay. But if it sticks around, that's something to worry about. Also, weight loss or weight gain, pants not fitting right, those are the big ones for ovarian cancer. Okay, and then on to cervical cancer, where we're going to spend a lot of time because there are good screening tests for cervical cancer, and we actually have a vaccine to prevent it. So this is one that is exciting to talk about because there's a lot we can do. So just a few pictures up here just to orient. We're talking about the cervix here, which is that gateway between the uterus and the vagina. The cervix is what dilates when you have a baby. When you hear people say like, oh, she's 6 centimeters dilated or whatever, that's the cervix dilating up to let the baby out. When you look inside the vagina with a speculum, this is what you see, or this. You see the cervix, it almost looks like a donut hole, or a donut with a little hole in the middle, and the hole is what goes into the uterus. The cells in the cervix are particularly sensitive and can develop precancerous changes or cancerous changes pretty quickly. And we're going to talk about the cause of those changes, the HPV virus. Another risk factor aside from the HPV virus is smoking. And the symptoms of cervical cancer, again, are going to be some of the same things we're just harping on over and over again. Bleeding, discharge, pelvic pain, bleeding after sex, bleeding between periods. Those are all things that should trigger you to go for an evaluation. Let's talk a little bit about what causes most cervical cancers. So most cervical cancers are actually caused by a virus, the human papillomavirus, or HPV. And often when you go for a pap smear, when you get the result, your doctor might say like, oh, your cells were normal and it was HPV negative, or you were negative but HPV positive. And you may wonder, like, what is that? HPV is a really common virus. Anyone who's ever had like any sexual contact at all probably has it or has had it. Like, we all have it. It's just like everywhere. Unfortunately, it affects women much more than men. But even in the case of women, most of us will clear the infection within a year or two of initial infection. Your body will just take care of it. But there are certain high-risk HPV strains that can induce precancerous or cancerous lesions in the cervix. So that isn't something that happens overnight. It actually probably takes 10 to 15 years from the initial HPV infection to develop into a cervical cancer. So this is why you got to go and get your pap smears, because usually if you're getting the regular pap smears, then we can detect it before it becomes that sort of problem. And it's rare to diagnose a cervical cancer in a woman who's had regular pap smears. Just a little schematic here showing that the HPV virus, although it's best known for cervical cancer, it can be associated with vulvar cancer, penile cancer, and then some head and neck cancers as well. So the most well-known type is cervical cancer, but is associated with these other cancer types. And then most of the cancers are from the high-risk HPV. The low-risk HPV types don't usually cause cancer, but they cause genital warts and other things that are just like unpleasant to have to deal with. So if you have an abnormal pap smear when you go to the doctor, or you have an HPV positive test, you may wonder like what's going to happen next. And some of you may have been through this as well. Usually if you have a positive or abnormal pap smear or a positive HPV test, then the next step is going to be something called a colposcopy. That's just a fancy word for looking at the cervix with a microscope. So you can see here in this picture, the doctor is looking through a microscope, and she has the speculum inside the vagina looking at the cervix, and it's just magnifying everything because you are a little bit of a distance away. And often they put a little solution on the cervix during this test, and the solution is acetic acid or vinegar. It's literally vinegar like you'd have in your kitchen, and it helps highlight any abnormal areas. So the precancerous cells or the abnormal changes from the HPV virus will like light up. They turn bright white, so then we know where to take a biopsy to determine is it just changes from HPV, is it precancer, is it cancer? And so when you have this procedure, you would usually wait a week or two and get the biopsy result and kind of go from there. And then if you do have abnormal cells, so you've had the colposcopy and there were precancerous cells identified, then the next step is usually to remove the precancerous cells. So that's done with something called a loop electrode excision procedure, which is also referred to as LEAP, or a cone biopsy. Sometimes this procedure is done in the operating room, sometimes it's just done in the office under some local anesthetic. Basically, this is just excising those abnormal cells to hopefully get rid of them. And the nice side effect of this is sometimes when we do this, there's so much inflammation from the procedure that your own immune system like wakes up and is like, hey, what's with this virus that's here? And then you can clear the HPV on your own. So it's good to have the procedure if you need it. Often you just need the LEAP and then you're done and your pap smears will return to normal. But it is, nerve-wracking to think about undergoing the procedure. Even better news, other than you hopefully just need this minor procedure and you won't get cervical cancer, is that we actually have a vaccine for cervical cancer. So there is a vaccine that's available. So we are vaccinating boys and girls at age 11 and 12 starting to be protected against the most high-risk causes of HPV. So the high-risk strains, there also are a couple low-risk strains in there to prevent genital warts. But it can be given to children as part of their normal vaccination schedule. And then older teenagers and young adults require 3 doses, and then adults also require 3 doses. It is approved by the CDC up to age 45. So even if you think like, oh, I probably already had HPV, or like, I don't really need it, like it's not a bad idea to think about it. Because even if you've had it before, maybe you didn't have the high-risk strain, or maybe you're going to get exposed to the high-risk strain later in life. So definitely this is like one of the few cancers that we actually have a vaccine for. So this is just something you have to think about and have to do if you can. And then lastly, the last cancer we're going to focus on today is the vulvar and vaginal cancers. So like I said, the vulva is just that external genitalia skin, and then the vagina is that little hollow tube between the outside and the cervix. You can get cancers in there as well. It's less common. but they can be associated with age, and they also can be associated with the HPV virus. So people that have abnormal pap smears and have the HPV virus might be at higher risk for a vulvar cancer as well. Additionally, as you get closer to menopause and there's less estrogen in the tissues on the vulva and we have what's called atrophy, that can put you at high risk too for inflammation and precancerous or cancerous lesions. Smoking also super bad in general, but raises the risk of an HPV associated cancer like cervical or vulvar cancer. Usually a vulvar cancer is going to present, you can see this kind of picture here, like a lump or a bump or a sore on the outside of the vulva. And so this is an area of skin, like if it hurts or it bleeds, you're probably going to notice it, but if like it's not really hurting, you might not notice it, because like this is a part of your body that is really hard for you to see. Like, you know, you can't get this view unless you've got like a mirror and I don't know. So this is why another reason it's important when you go for your well person exam with your doctor every year, you know, whether you're seeing your primary care or your OBGYN, it's a good idea for someone to look at this skin down there, because otherwise, like, who knows when someone's going to see it. And the same thing, you know, reporting any abnormal bleeding or pain or if you have any sores. So that, you know, is vulvar and vaginal cancer, which, like I said, is pretty rare, but still important to think about and often can be prevented, because usually it's not like you wake up one day and you have a lesion like this. It's like there's a little bump or a sore that's a precancerous lesion that can usually just be excised. And then just a few take-home points about cancer in general. So I think we covered this, but bleeding after menopause is definitely not normal. Like that is like a drop everything, call your doctor, make an appointment, expect that you may need a biopsy. If you continue your regular follow-ups of your pap smears and you get your HPV vaccination, you are very unlikely to ever get cervical cancer. Now, of course, there are always, you know, rare types and things like that, but really unlikely if you've had regular follow-up. A few years ago, we did transition to having less frequent pap smears. You know, you used to have to get a pap smear every single year. Now it's like every 3 to 5 years, depending on your age and other risk factors. And that's because we know it takes years and years for these problems to develop, but you should still go, even if it's not as frequently as you used to go. And then again, just having somebody look at that skin on the outside of the vulva, because there is not, you know, it's not an easy area for you to see. And then in regards to ovarian cancer and breast cancer risk, if you have a family history and you know, you ask your family member, or maybe they're not available to ask, did you have genetic testing? Even if they didn't have genetic testing, or you don't know, or maybe it was negative but it was a long time ago, just a good thing to think about asking your doctor if you should see a genetic counselor, because they can at least counsel you, take a good family history, decide if you qualify for genetic testing. Because if you do have a gene that puts you at higher risk for breast and ovarian cancer, there are preventative surgeries that are often done to help prevent you from getting those cancers. Lastly, I'll just share a few resources. If you're looking for more information, this OROC, or Outrun Ovarian Cancer, is an organization that's local right here in Cleveland, started by one of our ovarian cancer patients, one of their families. They have a run every year. It just happened in August. It's the first weekend in August every year, but their website has a lot of good information about ovarian cancer prevention and treatment, and links to support. The Foundation for Women's Cancer is another nonprofit that's a national organization that has a lot of information about the GYN cancers. Right now they're having their Move for Her initiative because it's Gynecologic Cancer Awareness Month, so they have a lot of good information on screening and like what you should and should not be doing. And then the Society for GYN Oncology, or SGO, is like our big leading organization. They provide a lot of guidance on, you know, if you have cancer, like what to do with some of your symptoms, or what to do to screen for other cancers. And then, of course, the American Cancer Society. And then UH, you know, Seidman Cancer Center, we have some information back there at our table. We're always available to answer questions. That was all I had as far as information. I know there is someone who would like to share, but we have time for questions. Anyone? Questions? Oh, go ahead.
So I've already gone through genetic testing, and I know I carry the BRCA gene. Two of my sisters have had radical mastectomies and nephrectomies before the age of 40. I'm begun the process to have it done myself, even though I do not have breast cancer, ovarian, or uterine cancer. I've begun the process to have or lessen the likelihood. Is there any tips that you have for me to get through the rigorous process of my insurance company talking to me?
That's a really great question. You know, if you have the mutation and you've had the genetic testing, you are at higher risk for definitely breast and ovarian cancer, and it is definitely recommended to have surgery to have those organs removed. Usually, when I have a patient in this situation, as long as we submit the paperwork with that diagnosis, the reason for the surgery is BRCA2 mutation or BRCA mutation. I've not had anyone where it wasn't covered. The only hiccups I can foresee is sometimes patients choose also to have the hysterectomy at the time of the oophorectomy, so uterus removed along with ovaries. There's just not enough data to show that there's an increase in uterine cancer risk with a BRCA mutation. So some insurance companies will push back and say like, oh, but you know, you don't really have a uterine cancer risk, so we'll pay for you to have your ovaries out, but we're not going to pay for the hysterectomy, which is kind of silly because, you know, you're in there and it's, you know, to us it seems silly. So often you have to find some other reason, and I would never say that you would lie, but you might have to remember, you know, if you have painful periods or heavy periods or pain or some other reason that you might need a hysterectomy. There are many diagnoses that can lead to the need for a hysterectomy, you know, that could also be used in concurrence with that BRCA mutation. But you really shouldn't have any trouble having the mastectomy or the oophorectomy covered.
With the mastectomy, just I looked at it as well, it actually be also I want to have the lymph nodes removed.
From the breast, from the... So I think that would be a little tricky too, because I'll admit I'm not a breast surgeon, so I'm not an expert, but it's my understanding that if you have the risk-reducing mastectomy, it's usually just the full mastectomy, and they don't typically remove lymph nodes. Now, certainly if they found something, that might be something to consider, but in general, adding like a lymph node dissection to another surgery does increase the risk and time of the surgery, and there can be complications from a lymph node dissection. You know, lymphedema, where you get permanent swelling of your arm or your legs, that can be devastating to try to deal with. And so I would imagine that's why it would be harder to get something like that to get approved. Mm-hmm. Yeah. Chesley?
Can you tell me what a person's risk might be if they have never had children versus if they've had children for those types of cancers?
Yes, so I did have on one of the slides that your risk for ovarian cancer does go up slightly if you have never had children. The reason behind that is that more ovulation times increases the risk for the ovarian cancer. So when you're pregnant, that's like almost a whole year of not ovulating. And then if you breastfeed for some amount of time, that's another whole year maybe of not ovulating. And if you have several pregnancies, you're really reducing the risk. So the risk for ovarian cancer is pretty low in the general population, like 1 to 2%. And it's probably not that much higher if you don't have children, maybe on the order of 3 or 4%, but it's not dramatically higher, as opposed to the BRCA mutations where it's like 20, it could be like 20 or 30% risk for ovarian cancer. So it's increased, but it's not a dramatic increase, I guess I would say.
And one more slide. So we really encourage women and families to have discussions around the HPV vaccine. But we see in the city of Cleveland, it doesn't have the same uptake as other areas of the country. And can you speak a little bit about maybe why that is, or why we think patients don't want that for themselves or their kids?
Yeah, I think there can be barriers to any vaccine, and I think, you know, when the vaccines were first introduced, there was a lot of resistance, especially to give them to children, because parents were saying, like, does this mean that I'm condoning that my child is going to have sex? And I think there is a little bit of that, like, fear, like, oh, if I give my child this vaccine, does that mean that they're going to think, well, I can go and have unprotected sex and everything's going to be fine? And that's certainly not what we're trying to say. But just like any other sort of education about reproduction, like, our children are eventually probably going to have sex, probably sooner than we think. And so I think really just saying that this should be across the board for everyone. It's not just girls, it's boys too. And this is really a vaccine that prevents cancer, which is really rare. So like, we really need to just do it and try not to think that it means we're condoning any certain sort of behavior, you know, in our children. And honestly, you know, when your child is 10 or 11 and you're taking them for their shots, you know, at the doctor's office, they're not really probably asking too many questions about what exactly the shot is for. And honestly, you know, but also that is that age when they may be starting to think about things and how babies are made and reproduction, and like just being honest with them, like, this is something you can do to prevent an infection in yourself, prevent infections in your future partners. You know, this is helping multiple people by you getting this vaccine. So I think it's actually a good education opportunity for your children. Mm-hmm.
I have a question.
Yeah.
All three of my children, boys and girls, received the vaccine. I may have misunderstood, but can men, boys be a carrier for this vaccine, for this virus?
Yes, the men can carry the virus and can pass it to their partners. They can get penile cancer. It's much less common, less likely for that to happen. In most cases, they're just carriers. But yes, so that's why they should be vaccinated as well. Mm-hmm. Yeah. Well, go ahead.
I know you said the age range for the HPV vaccine is 27 through 45. Is there something before or after that age time?
So you can get it if you don't get it as a like child at age 11 or 12. You can get it during your preteen or adolescent years, and then there's like a different categorization for adult vaccination that starts at age 27. But before that, you can still get it. It just falls under the other indication.
Okay, what about after the age 45?
So after age 45, it could be tricky without paying for it out of pocket, just because the CDC has not endorsed it as like a recommendation after the age of 45. It doesn't mean you can't get it, just might mean that you would have to pay for it. Because the insurance may not cover it. Oh, go ahead, sorry.
So as a teenager, I did get the HPV vaccine. I got it, I think it was only 2 doses. So as an adult, should I try to get it though? Is that something?
No, it depends on the formulation you had, and there are a couple different formulations. Most of them for teenagers are just the 2 doses, but then the newest formulation for adults is 3. So if you had it several years ago and you had the course, you don't need to get it again. Yeah, but there are a couple different formulations that were approved. All right. Did you want to come up and share?
Mm-hmm. So I wanted to share my story about my journey with cancer, and as relates to this. And I reached out to Wellness Works, and they offered to let me share. So I just have like a couple minutes. So I'm going to read from this, because I've actually never really spoken to a group like this about my journey with this. So forgive me, and we're all women in here except for the cameraman. So some of this stuff I try not to go into like too much detail, but anyway. So like I said, today I wanted to share my story with you. As an adult, I always had irregular cycles. In the spring of 2021, I experienced 2 very heavy episodes of bleeding in a fairly short period of time. Concerned, I saw my gynecologist. He suggested I go in birth control to help regulate my cycles. Although they became regular, heavy bleeding continued, sometimes with pain. One day in June, I was at work and I experienced such great pain and heavy bleeding that I let my director know that I needed to leave for the day. Moments later, the pain was so intense that my coworker called 911, and I went to Lifton Hospital, where multiple tests were conducted. I was losing a lot of blood. I was given the diagnosis at that time of adenomyosis and told to follow up with my doctor. At my follow-up appointment, I was given some help to manage the pain. I was told that if the symptoms continued, we should do additional testing. The symptoms continued and the frequency increased. I started experiencing other symptoms, much of which were mentioned in her slides. And then I later realized that the symptoms I experienced were warning signs of cancer. At my annual exam, the doctor ordered a special type of ultrasound, which was scheduled in October. I will never forget the look on the doctor's face as she got ready to administer the test in disbelief, saying that she could not believe that it had only been at my annual exam 6 weeks earlier. She wanted to do a biopsy that she saw a large, what we thought was maybe a large polyp, concerned it was cancer. The result came back as benign. I was relieved, but still had to have surgery to remove it. My surgery was scheduled for mid-December. Meanwhile, the heavy bleeding and pain continued and increased in frequency. The surgery appeared to be successful, and what we thought was a polyp, was the size of a finger, was removed. 3 days before Christmas, I got a call from my doctor informing me that I had uterine sarcoma. I had to wait 2 weeks, which felt like an eternity, to see an oncologist. Quickly, I went in for many tests and found that my cancer did not appear to have metastasized. Less than a month later, I was in for surgery. I had a total hysterectomy, including my ovaries and fallopian tubes. Testing determined that the cancer was about halfway through my uterus, but they felt they removed it all. Although I've had a few scares, I currently appear to be cancer-free. I've had a few areas that the doctor continues to monitor, and I go for scans and see my oncologist every 3 to 4 months. I consider myself very lucky. Uterine sarcoma is a rare form of uterine cancer in which about 1,200 women a year are diagnosed. My subtype is considered aggressive. While there are no early detection methods for my type of cancer, I know and feel that listening to my body, knowing something just wasn't right, and being persistent with my doctor led to early detection. I strongly should encourage you to do the same and encourage those you love to do the same. I really believe that early detection, along with access to good health care, is what would save my life, and it could save yours as well.
Thank you for sharing those. That was great. And I think you made a great point about, like, if something doesn't seem right, going back and saying, this doesn't seem right, my symptoms didn't get better with the interventions we tried. Like, that's it's a really important message. So thank you for sharing with us today. And thank you all for coming.
Yeah.